There we go. All right. Well, thank you very much for the opportunity to be here. And again, following Dr. Moti is always tough, especially when he gets to talk about cure. But what I'm going to do in the next few moments is try and give you some semblance of how I think that the world, with multiple novel agents available in the relapsed and refractory setting, is evolving. And I think that's an important statement, that it is evolving. And try and answer this question about, is there an ideal sequence for anti-myeloma agents in the relapsed and refractory setting? So I think to start off with, I think it is important to set the benchmark for where we are in 2022. This is data from our RVD 1000 series that we published in JCO in 2020 and just updated at ASCO this past year. And what the RVD 1000 series demonstrated was that on average, the median progression-free survival with patients who receive RVD induction, single transplant, and risk-adapted maintenance is 65 months, 5.5 years. And in fact, we predicted the continuous len transplant arm of determination. With our update, we're at 68 months that we presented at ASCO. I think determination was 67 months. So we anticipated what determination was going to show in a much larger patient population even than that. What we also demonstrated is that the median overall survival is 126 months, which is basically 10 years. And again, that's for everybody. And if you look at the bottom two curves here, what you'll see is that median PFS for a standard risk patient is almost 80 months. And median overall survival for a standard risk patient has not been reached now with the median follow-up of over 12 years. But it looks like it's at least close to 14 plus years is the median expected overall survival. Now, unfortunately, as good as these curves look, what I think you'll notice is that there does not appear to be a plateau on either the PFS or the overall survival curve, as suggested by Dr. Moti previously. And so the real question then is, how do we begin to manage that subset of patients with relapsed disease? And what I think you'll see here is the factors that we all think about when we make decisions about managing relapsed disease. These include things like frailty, disease morbidity, risk, treatment history, what did they previously receive, and then lifestyle. And lifestyle, at least for us, is a big deal because some patients drive 4 and 5 hours to get to us and they don't want to come every week for an infusion. They'd rather take something oral. By the same token, sometimes oral drugs end up being more costly for the patient out of pocket, and so they want something IV. So these are all factors that we put into making decisions, including these blue boxes underneath here. But at the end of the day, the most effective regimen is the one that improves the best outcome, gives you the best outcome, and does, in fact, some way maintain quality of life. Now, when we think about myeloma historically, we have thought about 3 sets of backbones of agents. We've thought in the early 2000s about proteasome inhibitor backbones, and we would add things to bortezomib. Then with the approval of lenalidomide and subsequently pomalidomide, we thought about IMiD backbones. And most recently, I think particularly in the early relapse setting, I think what we want to talk about is CD38 antibody backbones. Because the real question for an anti-CD38 naive patient or not resistant patient is, what are you going to partner with an anti-CD38 antibody to really ultimately improve the outcomes in first relapse? And the reason I say that is that I think that early relapse, particularly first relapse, is the newly diagnosed myeloma. Our goal should be to try to achieve deep responses, and that those deep responses can last as long, sometimes even longer than what that first remission was, even with highly effective therapy. So the question really becomes, you take an anti-CD38, do you add an IMiD to it, or do you add a PI to it? And that really is an important part of the discussion. Now, there have been a number of trials that have used Lendex as a backbone. And so when we think about these 4 trials, you're going to see IRD versus RD, ERD versus RD, KRD versus RD, or DRD versus RD. These are all really important historical trials. But in the modern era of myeloma therapy, where patients receive continuous lenalidomide maintenance after induction therapy, these trials now are useless. They really don't provide us any significant information. And I say that because all of these trials did not have patients who were resistant to lenalidomide when they came on the study. And if a patient is receiving len maintenance, until progression, they are functionally lenalidomide resistant. So you're not going to get these kinds of hazard ratios. You're not going to get these kinds of PFS for the experimental arm that you saw in this trial. And so for that reason, I think it's important that we not use lenalidomide-based controls or triplets in the context of relapsed myeloma that's progressing on len maintenance. Now, there are other trials that we can learn from, and these include ones that use bortezomib-based approaches. You can see here the PVD versus VD, DVD, KD versus VD, or selinexor. We're going to talk briefly about selinexor, and then we're going to have a moment or two talking about venetoclax. I don't think about this as first relapse for the average patient with myeloma, but there may be subsets where it's certainly worth considering that as well. What about the other IMiD that I think we can consider? Well, there are a number of trials that have looked at pomalidomide-based controls in the context of relapsed and refractory myeloma. These include combinations with bortezomib, combinations with carfilzomib, combinations with daratumumab, ixazomib, elotuzumab, and isatuximab, the other anti-CD38 antibody. And we're going to talk about these approaches in a little bit more detail. So I want to start off giving you what has been our historical go-to in the context of first relapse myeloma, and that has been dara-pom-dex. And this is really based on a paper that we published many years ago looking at the combination of dara-pom-dex in early relapsed myeloma. And what I think you're seeing, at least in the cohort of patients that were dara and pom naive, is that the median PFS and OS was really quite good. And in fact, it looks like it's somewhere between 3 and 4 years for the median progression-free survival. And based on this, dara-pom-dex has become our go-to as an institution in terms of how we approach the management of patients with first relapsed multiple myeloma. Now, that was retrospective single institution data. And so the randomized phase 3 trial evaluating dara-pom-dex versus pom-dex was the Apollo trial. And what you're seeing here is a median PFS of about 12 months for the DPD arm compared to only 6.9 months for the pom-dex arm. And the first question you may be saying is, well, why is there such a discrepancy between the phase 3 trial and what I showed you before as the phase 2 trial? The reason is that these patients have had more prior therapy coming in than in our experience that I showed you before. So in our historical retrospective study, we'd seen a median prior number of lines of therapy of 1. All of these pomalidomide control trials are looking at a median prior lines of therapy of between 2 and 3. So it's a later line of therapy, which in my mind eliminates the ability to compare head-to-head with other phase 3 trials that look at median prior number of lines of therapy of 1 to 2. So they may be equally effective, but if you're looking at it in a later line of therapy, you may not necessarily see that. So this doesn't discourage me from using dara-pom-dex. I just want to think about where I'm going to use that and where I'm going to get the most mileage out of it. Now, the Candor trial looked at dara-cardex versus cardex in relapsed refractory myeloma. And again, if you just look at this on the surface, you're going to say, well, these PFSs look much better than the POM combination I showed you before, and that may in fact be the case. But in these trials, they had a median of 1 to 2 prior lines of therapy, so we're an earlier therapy line. Now, importantly, the KD arm performed about as well as we would have expected. So this benefit that you're seeing with the dara-cardex is likely real. And the real question is, when it comes down to patient preferences and differences, does a patient want a CAR-based combination, or do they want a POM-based partner with an anti-CD38 in the context of first relapse? So Icaria is another trial, only used isatuximab in combination with pom-dex versus pom-dex in relapse. Again, what you're seeing is almost identical progression-free survival curves, 11.5 months versus 6.4. Hazard ratios pretty similar to what I showed you for Apollo. And when I think about practical differences between isatuximab and daratumumab in partnership with either POM or carfilzomib, I think of them as being relatively interchangeable. I don't think of one necessarily being better than the other. I think it really comes down to route of administration, adverse events, and dose and treatment schedule more than anything else. Again, if you look at IKEMA, this is ESA-CAR-Dex versus Dex versus CAR-Dex. Again, what you're seeing is a big difference in overall response rate favoring the triplet. And in fact, if you look at progression-free survival curves, this looks almost identical to what I showed you in the CANDOR study. The KD arm did a little bit better, 19 months instead of 16 months. And the ESA KD arm may have done a little bit better as well. But again, that's the hazard ratio was about the same at about 0.531, suggesting these again were somewhat similar between the two treatment arms. So again, it's really a matter of preference. Do you want to use ESA or DARA? And if you do choose one of those two anti-CD38 antibodies, then are you going to partner it with carfilzomib, or are you going to partner it with pomalidomide? And as I said, I think the CAR and the POM trials are hard to compare head-to-head because there's a lines of therapy difference between those two studies. Now, another drug that I think is worth thinking about, particularly in patients that are in second or third line therapy who are POM naive, is the ELO-POM-DEX combination. And again, what you'll see here is median PFS of about almost 11 months versus 5.6 months here for POM-DEX. Again, this is a lines of therapy issue. It's a 3 or more prior lines of therapy for on an average here. But I think what you're seeing is that if a patient gets a carfilzomib-based regimen in first salvage, then you could consider POM and ELO in second salvage as an alternative salvage regimen for these folks as well. Now, you're probably saying to yourself right now, how am I going to decide whether I'm going to partner CAR or POM with an anti-CD38 antibody? And so to further try and answer that question, our group presented at ASH this year a retrospective analysis looking at DARA-POM-DEX in all of the patients that we treated. And what we showed was that the median progression-free survival was really dependent in part on how long that first remission lasted before they came to relapsed myeloma. If their first remission lasted 30 months or more, so from the time of diagnosis to when they relapsed, this was the PFS curve for DARA-POM-DEX. On the other hand, if their time from diagnosis to first relapse was less than 30 months, this was their median PFS. So it was relatively shorter for those high risk, the functional high risk patients. And so in this context, actually, we would recommend using CAR with DARA-DEX. Whereas for these patients who had more than 30 months since diagnosis, we would likely continue our current standard of DARA-POM-DEX. So this is one way to begin to think about it. Others may be infusion versus oral partner for an anti-CD38 antibody. These are some areas where you can make some judgments based on quality of life and other things that a patient may request. Now, I did mention the selinexor combination, and so I want to give you a little background on selinexor. It's an XPO1 inhibitor. Selinexor is FDA approved in the US in combination with dexamethasone on a twice-a-week dose and schedule at 80 milligrams based on the STORM study, which gave you a 26% response rate, VGPR or better rate of 4.9%, PR of 19.7, and DOR was about 4.4 months, median PFS was about 3 months, median overall survival was about 8.6 months. Now, what we know about selinexor in the refractory setting is that this dose and schedule is really hard to give. And so I think most folks have adopted alternative doses and schedules, and the Boston trial gives us some data, although in an earlier relapse setting, for how to approach the use of selinexor even in the late relapse setting. And what this trial did was look at selinexor in combination with bortezomib-dex, giving once-a-week selinexor and once-a-week bortezomib, and compared it with standard bortezomib-dex, giving twice-a-week bortezomib in combination with dexamethasone. And what it showed was a clear improvement in progression-free survival. Now, this is 1 to 3 prior lines of therapy, so this is not a later relapse patient population, but the adverse event profile was much better. And for that reason, I think does give us good data to suggest that selinexor once a week in partnership with a proteasome inhibitor, there's more data with bortezomib than there is with carfilzomib. These combinations certainly seem reasonable in this context. Now, I want to take a moment and talk a little bit about the concept of precision medicine in myeloma. And I want to talk about precision medicine in myeloma because I think we have this story. It got derailed a little bit by an ill-informed randomized phase 3 trial. But I think the core pieces of precision medicine are still here and I think are really, in fact, quite important. So there was a phase 1 study done looking at venetoclax, a single agent, in relapsed and refractory myeloma. And when we started enrolling patients on this trial, one of our basic scientists, Larry Boyce, said, don't put non-1114 patients on here. Only put 1114 patients on there. And so that's all we put on there. And if you look at the non-1114 patients here, the response rates to venetoclax was only 6%. If you look at the 1114, it was 40%. And if you look at all patients, meaning the 36 plus the 30 that were 1114, it's about 21%. And I give Dr. Boyes, our laboratory scientist, a lot of credit in this, because had it not been for him driving us to use the 1114 subset, this trial may have been viewed as a negative overall trial. We then subsequently suggested a phase 1 combining venetoclax with dexamethasone based on laboratory data. And what you see here is in the phase 1 portion, overall response rate was 60%. In the phase 2 portion, overall response rate was about 50%. And this, to me, led to the idea that we should really focus on Vendex in the 1114 subset of patients. Unfortunately, a trial was done that did not follow this precision medicine concept. And what was done was the Bellini trial, which was venetoclax with bortezomib dex versus bortezomib dex in a randomized phase 3 trial. And this had 2-to-1 randomization favoring venetoclax over placebo. And this took everybody. It didn't just take the 1114 patients. What we saw in that trial was that the progression-free survival clearly favored the use of venetoclax, but that the overall survival was actually worse for the group that got venetoclax compared to the group that did not. And this led to huge amounts of consternation and concern. What was venetoclax doing to really make things worse overall? And was this a significant concern? And so we went back and analyzed in this trial what happened to the 1114 patients. And what we saw was a significant improvement in progression-free survival, significant improvement in MRD negativity with the group that got venetoclax in the 1114 subset, and no negative impact on overall survival. That negative impact on overall survival really came from the non-1114 patients, particularly the high-risk patients, where bortezomib dex alone simply was not sufficient. And we don't know what venetoclax was doing to the biology of those cells as well. And in fact, if you look at hazard ratios in the 1114 subset, in terms of PFS hazard ratio of 0.12, that's an 88% risk reduction with the use of venetoclax in the 1114 subset. And if you look at overall survival, hazard ratio of 0.61, suggesting, again, no significant impact in the group that was 1114 positive. There are now trials evaluating the combination of Ven-Dex with Dara, looking at 2 different doses of venetoclax, 400 and 800. 800 was the dose that I showed you in that phase 1 study of venetoclax plus dexamethasone. And based on safety concerns with this, in the Bellini trial, the FDA required that there be a third arm that's a control arm just to compare how people are doing. And what we see here overall is that the response rate between the 400 and the 800 milligram of venetoclax is somewhat similar. The CR rates are similar. The MRD negativity rates are similar. And across the board, it is better than the group who has 1114 myeloma, but did not get venetoclax overall. And in fact, this is now giving rise, we hope, to an FDA label for the 1114 subset with venetoclax dex and venetoclax daratumumab and dexamethasone. Now, the last section that I'm going to talk about here really focuses on the new holy grail, what everybody's excited about in the context of myeloma, which is BCMA-directed therapy in the context of myeloma. We know that BCMA is an important target on plasma cells and is not only important because it is a surface receptor there, but also mediates many of the drug resistance pathways that are important in the context of a drug resistance, proliferation, and survival in the setting of the bone marrow microenvironment. So simply by binding BCMA, we may not only have a great immune target, but we may also interrupt some of those drug resistance pathways that are so important for keeping cells alive in the context of the bone marrow microenvironment. Now, we do have a number of different ways to target BCMA. We have antibody drug conjugates, we have bispecific antibodies, we have bispecific T-cell engagers, and then we have CAR T-cells, all of which are currently available in the US right now. So this is data on the DREAM2 study, which led to the FDA approval of belantamab mafodotin. This was the 2.5 mg per kg dose from that randomized phase 2 trial. And what you saw in refractory myeloma with a median of 6 to 7 prior lines of therapy was a 32% overall response rate, median duration of response of about 11 months, and that this could be managed through dose holds and dose modifications. And the dose holds and dose modifications really relate to the ocular toxicity known as keratopathy that is a consequence of the chemotherapy linker, MMAF. And what we saw in the DREAM2 study was that keratopathy did occur in about 72% of patients, but symptomatic keratopathy only occurred in 56% of patients. And actually, if you're looking at patients who had best corrected visual acuity changes of 20/50 or worse, meaning 2 lines on a Snellen eye chart, that was only 18%. So 1 in 5 had visual changes that were this severe. Most patients just had dry eyes or itchy eyes, and in fact, only 3 patients had to discontinue due to corneal adverse events. So this can be managed with dose holds and dose modifications. And I think from a patient perspective and an ease of administration, if you have an ophthalmologist that's partnered with you, this is one of the easiest drugs to give in myeloma because it's 1 drug every 3 weeks, and then you partner with an ophthalmologist to decide if you're going to give the next drug, next dose 3 weeks later. Now, the other drugs that everybody's really excited about are CAR T cells. This is the data on ide-cel as published from the KarMMa study in the New England Journal back in 2021. This looks at the overall response rate by dose, and you can see 450 gave an overall response rate of about 81%. And in fact, if you look at progression-free survival in a median of 6 to 7 prior lines of therapy, very encouraging data and a higher response rate than we've seen with pretty much anything else that's approved at that time when ide-cel was first FDA approved. Unfortunately, unlike other CAR T-cell products that we've seen in ALL or diffuse large B-cell lymphoma, we have not seen a plateau on this curve yet. And there are a number of questions about why that, in fact, may be the case. But I think the way to think about it in my mind is this is the first generation of CAR T-cell products, and we need to see the second and third generation and perhaps even consider a role for maintenance therapy afterwards to try and maximize the benefit of CAR T-cells because clearly they're very effective at inducing a deep response. We just have to figure out how to maintain that response over time. Now, the other FDA-approved CAR T-cell in the U.S. is cilta-cel, and that's based on the CARTITUDE-1 study, a phase 1/2 study of cilta-cel in patients with relapsed and refractory myeloma. Again, heavily pretreated, 6 to 7 prior lines of therapy. Overall response rate was 98%, as updated by Dr. Usmani at ASCO this year. And again, if you look at PFS for all patients, it has not been reached with over 2 years of follow-up. We still don't know yet whether there's a plateau here. I'm hopeful there will be a plateau, but we'll just have to see whether this too has a continued desultory PFS curve or whether this truly does represent a potential curative opportunity for patients with relapsed and refractory myeloma, and whether moving it earlier in the disease course improves the potential outcomes for patients overall. Now, I'm going to end talking about BCMA-directed bispecifics, and there are non-BCMA-directed bispecifics that I'm not going to touch on just for the sake of time. But we know that these bispecific antibodies or T-cell engagers can be highly effective. We saw very interesting data from the Amgen initial BITE that suggested that even in refractory myeloma, 50 to 60% of patients could respond. What we've seen with teclistamab is an overall response rate of between 60 and 70% in refractory myeloma. There is the same toxicity we see with CARs, mainly CRS and neurotoxicity. but this appears on average to be a grade lower than we've seen with CAR T cells. And in BCMA-directed CAR T cells, I think on average it's a grade lower than what we see with CD19-directed CAR T cells. So this, to me, is a very exciting and evolving field. We're waiting for the FDA approval in the US of teclistamab, but we also know that the Regeneron compound and the Pfizer compound are probably not far behind. And so hopefully we'll have a feast, if you will, of different bispecifics available for us in the near future that will allow us to really change the playing field and understand how to begin to think about sequencing these agents overall. So I think in conclusion, in early relapse, backbone agents like anti-CD38 directed, to me, the question is, do you partner it with an IMiD or a PI? In the context of next relapse, then if you use an IMiD up front, use a PI in the second relapse. If you use a PI up front, switch to an IMiD-based approach in the context of subsequent relapse. I think the 1114 data for precision medicine is really very exciting. And then again, novel BCMA targets, I think, are going to be big disruptors for us. But right now, they're going to be available in the context of refractory myeloma. So with that, I will stop. And again, this is the team that I work with, and I'm happy to take questions as time allows. Thank you.